Yes.
This meeting is being recorded.
Okay, so today I'll just be presenting about AmpC resistance. Uh, so these are some of the topics that I'm going to go over. The mechanisms of resistance. There is a guidance document released by IDSA regarding the treatment of AmpC-Enterobacterales in infections. So I thought it would be nice to go over that and a little bit about my research project that I'm doing with now. So a little bit of background. We know that antimicrobial resistance has been increasing. We also get consulted on a lot of patients with multi-drug resistant organisms. So it continues to be a global crisis. So in 2019, CDC released an estimate that collectively antimicrobial resistant pathogens, they caused more than 2.8 million infections and over 35,000 deaths annually in USA in the 5 years from 2012 to 2017. We have a lot of well-studied antibiotics for treating AmpC infections, but as we all know, there is confusion about which species that are at greatest risk for clinically significant AmpC production and the optimal treatment. I think uh, this is becoming more relevant of a topic, and we discuss it during rounds when we come across these patients, but also I think there's still some confusion when it comes to primary teams, and also when we're not involved in the care of these patients. So what are AmpC beta lactamases? So they belong to the amber class C serine beta lactamase enzymes. So they have serine residues at the active sites for catalysis. So when these organisms, some organisms are at moderate to high risk for resistance. So beta lactams can trigger a cascade of events which will lead to a significant AmpC production and beta lactam resistance, even though uh, these microorganisms demonstrate susceptibility on the initial isolates. So the risk of inducing AmpC production is different for different beta lactam antibiotics, as well as the species of bacteria that we're dealing with, which complicates the treatment decisions. So after beta lactam exposure ceases, sometimes the AmpC productions generally return to baseline, but there is an exception to this. I'm going to talk about these regulatory genes and mechanisms in the subsequent slides. But if we find that there are mutations in the regulatory genes, which are AM, D, R, and G, then overtranscription can occur even in the absence of beta lactam trigger. So it depends on what's the mechanism of resistance. So there are three well-known mechanisms. The first one is the inducible chromosomal resistance when exposed to beta lactams. The second one is a stable chromosomal derepression. And the third one is a plasmid-mediated AmpC gene. So the first one is through inducible resistance by a chromosomally encoded AmpC gene. So we see it in Enterobacter cloacae, Citrobacter frondiae, and the other organisms are Serratia marcescens and Pseudomonas. The second one is the stable chromosomal derepression. Um, these are because of promoter or attenuator mutations. You can see this in E. coli, Shigella, and Acinetobacter baumannii. And the third one is the plasmid-mediated resistance, which you can see in Kleb, E. coli, and Salmonella species. So the first one is the one we're gonna talk about more, but the other two mechanisms, they're constitutive and not induced. So in isolates in these cases, they're expected to test non-susceptible, to ceftriaxone and ceftazidime. So when you encounter these infections, these are like less confusing because you already know that the isolates are non-susceptible, so you're not going to use ceftriaxone and ceftazidime. But whereas in the former, the isolates will initially test susceptible, but then when you start treating with the third generation cephalosporin, even can get resistant as quickly as even a day on the treatment. So I just wanted to go over the mechanism because I found this really like interesting when reading about it. So the primary mechanism is like the AmpC, like hyperproduction. So when we look at this diagram, it's a bit confusing, but there are three main regulatory genes: the AmpR, that's the regulatory protein; the AmpT is the recycling protein; and the AmpG is the transporter protein, as you can see here. So when it comes to like AmpR, it is a regulatory protein. It keeps your AmpC beta lactamases in check. But when when this bacteria is exposed to like a beta lactam, it increases the cell wall degradation products. So usually um, the sites on the AmpR are limited. So the cell wall degradation products and these peptides, they compete for the same sites. And when these cell wall degradation products, when they're exposed to like a beta lactam, they're like overproduced. And so they cause conformational changes in the AmpR. So the function is disabled. So then the AmpC is not in check and it causes like a hyperexpression. The AmpT is a regulatory, is a recycling protein. So the cell wall degradation products are converted into peptides that can be used in the cell wall synthesis pathway. So when there is like a mutation in that gene, as it's shown here, then it reduces the ability to bind to AmpR and again causes overproduction of AmpC. So this is just the mechanism, and it was kind of like interesting to like see how it all works. So like I mentioned, the Enterobacter cloacae, Klebsiella aerogenes, and Citrobacter frondiae are at the moderate and high risk for clinically significant AmpC production, like we all know. And there are several reports which suggest that there is emergence of resistance after exposure to agents like ceftriaxone. It can occur in approximately 8 to 40% of infections caused by these organisms. The other organisms, the clinically significant AmpC production occurs in less than 5%. So increased AmpC production resulting from inducible AmpC expression can occur in the presence of specific antibiotics and results in sufficient enzyme in the periplasmic space. So that results in increased MICs and ceftriaxone and ceftazidime resistance. So like I mentioned, the isolate tests susceptible, but it exhibits non-susceptibility once the treatment is initiated. It can be observed very early, even with a few doses of exposure to these antibiotics. But the Enterobacterales isolate certain E. coli, A. baumannii, they are stably de-repressing the gene expression. And these are some of the plasmid-mediated AmpC genes, which are more commonly observed in E. coli, Kleb, and Salmonella. So at least when I started fellowship, I learned these acronyms like SPACE or SPICE that we talked about when we talk about these infections, but that has changed. And the three main bacteria that I mentioned, the Enterobacter cloacae, aerogenes, and Citrobacter frondiae are the main ones now. That harbors chromosomal AmpC, but Citrobacter cosseri does not. And the acronym also had indole positive protease species, but P. vulgaris and P. penneri, they do not contain chromosomal AmpC genes. And they've done studies which showed that Serratia, Morganella, and Providencia species are unlikely to overexpress AmpC based on both in vitro and clinical reports. So antimicrobials, we all know like intrinsic resistance can be seen with aminopenicillins, first generation cephalosporins, and augmentin, that potent inducers of AmpC. So they're usually like intrinsic resistance is seen, so we don't use these antibiotics. Um, the piptazo, third generation cephalosporins, and aztreonam, they're weak inducers, but if there's enough beta lactamase, then they're hydrolyzed. So that is reflected with the increased MICs. Cefepime has an advantage of being a weak inducer, and it also withstands hydrolyzation. Imipenem is a potent inducer, but it withstands hydrolyzation because of the formation of stable acyl enzyme complexes. The induction potential of ertapenem and meropenem has not been like formally investigated, but it's thought to be similar to imipenem, and they're generally able to resist AmpC hydrolysis. When we're thinking about treating these infections with like fluoroquinolones, aminoglycosides, and trimethoprim sulfa, tetracyclines, or any other like non-beta lactam antibiotics, they do not induce AmpC, and they're also not substrates for AmpC hydrolysis. So that gives us more options for oral step down or uncomplicated infections that we see with these organisms. So this is just a diagram showing the induction potential, and it differs by agent and species. So highest to lowest would be carbapenems and cefamycin. Although they have like a high induction potential, they're also like have the advantage of like withstanding hydrolysis. So they're actually a drug of choice in this infections. The aminopenicillins, like I mentioned, augmentin, they're all intrinsically resistant. And when you go down the list, I'm going to talk about in the subsequent slides that we can actually use Cefepime as well. So a little bit about the guidance document, which was released by IDSA for the treatment of these infections. They went over it very well in like there were like 7 questions most commonly, and they address like all these different antibiotics. So firstly, ceftriaxone and ceftazidime, they're not recommended for the treatment of invasive infections caused by these organisms, but they also do mention that when you encounter like a uncomplicated cystitis, you still can use ceftriaxone as a reasonable alternative. Um, of course, there is difference in the sources of infection, how sick the patient is, what are the pre-existing medical conditions. And interestingly, it also might depend on the ceftriaxone dosing and duration. So that just complicates how you interpret like the data for it, but it's usually not recommended in treating invasive infections. So Cefepime can be used. There is a meta-analysis including 7 studies which show it compared the clinical outcomes of patients receiving Cefepime versus carbapenems for these infections, and it did not find differences in clinical outcomes. So the guidance document says that Cefepime can be used as a treatment option when you see the MIC less than 2, but a carbapenem therapy is preferred when you see that the MICs are 4 to 8. So I did a journal club about this in the past, the Merino 2 trial, which says that carbapenems are the recommended treatment for serious infections which are caused by AmpC-producing gram-negative bacteria, but can select for carbapenem resistance, and piptazo may be a suitable alternative. So this slide is a little blurry, but these are the results from the Merino trial. And you can see like that outcomes were mortality, microbiological failure, and microbiological relapse. So the main conclusions from that trial were that there were no difference between piptazo and meropenem in terms of the composite primary endpoint. The microbiological failure, however, was more common in the piptazo group. The relapse was more common in the meropenem group, but also there were some limitations to that study. And it was also kind of difficult to like interpret those results. So piptazo, like something interesting about it is that the tazobactam is less effective at inhibiting the hydrolysis than the newer beta-lactamase inhibitors like avibactam, delabactam, and vaborbactam. So the Merino results are like challenging to interpret, and they said that like a larger RCT is needed for that. But there's two other observational studies which showed increased mortality in patients prescribed Piperacillin tazobactam. So IDSA recommends caution when using piptazo for serious infections, but it still is a reasonable choice in uncomplicated infections like cystitis. So what about the newer beta-lactam, beta-lactamase combinations and ceftorocol? It does mention that all of these agents are like very effective against AmpC infections, but obviously we do want to reserve them for patients with infections with organisms exhibiting carbapenem resistance. But also another interesting thing here is that ceftazidime tazobactam is not suggested to be used as an option for AmpC infections because there was a study that showed that it was active against only 19% of the E. cloacae isolates. So similar to how they mentioned about the tazobactam in piptazo, this is one of the newer antibiotics that's not recommended to be used in these patients. So like I mentioned, all the non-beta-lactam antibiotics, they're not substrates for AmpC. So you can like use these, they're reasonable options for oral step-down therapy for bloodstream infections if you have the isolate and the susceptibility is demonstrated. The patient has adequate source control, and if you think that the patient is hemodynamically stable to use this option, and also there is like less concern regarding intestinal absorption of these antibiotics. There was also mention about like nitrofurantoin Bactrim or a single dose of aminoglycoside as options for uncomplicated cystitis, which I found interesting because we do get consulted about patients who are otherwise stable, but with urine culture showing these bacteria, and we're consulted on these patients. We've never used it, but the single dose of aminoglycoside does sound like an option for uncomplicated cystitis, and would be interesting to see what your views are on that. They do recommend limiting the oral phosphomycin to E. coli cystitis only because the phos-A gene is intrinsic to many of these AmpC inducers, and it can hydrolyze the drug, which in turn leads to clinical failure. So after doing like a literature review and going over the recent like Marino, we wanted to look at the treatment options or like the antibiotics which are used in our hospital for the treatment of these infections. So we decided to start a multi-centered retrospective study so that we can examine the differential effect by antibiotics and AmpC-producing organisms. We decided to look at E. cloacae and Citrobacter frondiae as our primary like isolates, and the rest of the bacteria in that order. So our objectives were to look at the mortality for invasive infections and treatment emergent resistance. These are the outcomes of interest, and to determine if avoiding third generation cephalosporins is clinically appropriate for the Citrobacter frondiae group. So our research questions were among adult patients with positive cultures for these AmpC-producing Enterobacterales, if though is exposure to a third generation cephalosporin associated with emergence of resistance, and also if the relationship differ for like specific species. And we also decided to look at the duration of antibiotics and if the third generation cephalosporin dose is, if there's any relationship between that. And our inclusion criteria are adults over 18 years old. All the positive cultures, we have the microdata over the last few years. Like I said, E. cloacae and Klebsiella aerogenes and Citrobacter fluendiae are our main organisms that we're looking at. They need to be susceptible to third generation cephalosporins, and they're treated with at least one dose of antibiotic. Anyone who has missing data about the inclusion criteria, or that those patients would be like excluded. It's a retrospective chart review from 2014 to now, and multiple sites within RWJ Barnabas are involved. We plan to look at 1,000 charts, and we're using the REDCap database for data collection. So these are the outcomes we're looking at. Like, of course, the study is still in process, so I don't have any like results for you guys today, but our primary outcome is emergence of resistance to third generation cephalosporins within 30 days, or at a significant event like discharge or death, or an event like resistance. Our secondary outcomes are emergence of resistance in total hospitalization, treatment emergent resistance to third generation cephalosporins, and in hospital mortality at 13 days, 14 days, 30 days, and overall in hospital mortality, and length of hospitalization after the index culture. So our study is IRB approved, and the data collection is in process. So unfortunately, I don't have any results for you guys today, but I thought it would be a good opportunity to just go over the mechanism of resistance and what we're planning to do with the study. I think that's all I have from my end.
Divya, this is Keith. I want to compliment you. That was a very good talk, and I could tell that you've actually, gotten to understand some of the mechanisms, which are not simple, but when you understand them, you're like, oh, that's how it works.
Yeah, that's
So
how I felt.
I have a question for you, and I also just have 3 comments because I just can't help myself. First of all, do you have any idea whether any of the newer antibiotics you're going to be able to evaluate, any of the beta-lactam inhibitor combinations like Ceftazidime or Ceftazidime and tazobactam, or is there just not enough use here that you don't anticipate because that would be really cool information, you know?
Yeah. Um, we didn't really plan on doing that, and I'm not sure because yeah, maybe in the last like few
Yeah.
years we would be able to like get some data, but I'm not sure if it would
I
be a
would,
lot.
right. I would just say though, don't exclude those. Hang on to them, and
Okay.
you could probably even do. I don't know what's out there in the literature. Navin, you probably know better. But you could even have like an abstract at ID Week or something, reporting 5 cases treated with newer agents or something. So the just a few comments. So
Yeah.
it's important to differentiate, and this is something that when Jason Pogue gave his talk on Pseudomonas really made me, really hit home. Meropenem is really kind of a weak inducer of AmpC. So imipenem is sort of a flawed carbapenem because it induces AmpC and it's not as stable to AmpC as is meropenem. Meropenem is really a weak inducer, and the reason why that matters is because with imipenem relebactam, that's part of the problem is that IMI induces AmpC, and the AmpC can sort of, that's why relebactam helps because relebactam can kind of inhibit that AmpC. So Mero is really kind of a perfect drug in many ways from the armamentarium that we have in terms of AmpC, managing AmpC producers. It's really good. And Nav probably knows, but I don't think ERTA is a big time inducer either, right? I mean, that's why we use those 2 drugs often, inpatient, outpatient.
Yeah, I don't think so either. And it's just a good point because, with IMI-REL, with Pseudomonas, you get significant activity sort of restored, but with Mero-Vapor, you don't.
Mero, it doesn't matter. Mero's 30, right?
Because if it is going to be resistant against Mero, it's more efflux, which it's not going to be cured with that. But with IMI-REL, it's usually porins plus AmpC, and if you get rid of the AmpC, then the porins by itself is not enough. So that's why you sort of see restored activity with drug-resistant Pseudomonas. So it's just interesting to see the difference between those 2.
Yeah, I hear you. So that's number 1. Number 2, I don't want to shatter your world, Divya, because I went through this when I was a fellow, and I think it was George Leopoulos who corrected me. So beta-lactams, you can induce AmpC production, but most of the time when there's emergence of resistance while therapy, you're actually selecting for stately de-repressed mutants that are already there. So it sounds cool that, oh my God, there was nothing there. I gave this antibiotic, it became resistant. And that is what happened, but it's not necessarily because this time you induced AmpC production. So it's just interesting. So, technically speaking, it's usually selection of a de-repressed mutant. And I would just say, I would avoid 3rd-generation cephalosporins, even in a UTI. If you want to send them home on that, that's fine. Just from an infection control and stewardship perspective, just don't do it in the hospital because even if you don't select their Enterobacter in their urine for UTI, I mean, you can certainly select it, elsewhere. So I still would, avoid 3rd-generation cephalosporins. I understand once-a-day dosing, it may be good in the outpatient setting, but inpatient, just use Cefepime. I just feel better about it. So that's it. Great job. And make sure you publish your results.
Yeah.
Just because you're leading fellowship, it's hard, but make sure that you publish your results, okay? And Nav will keep after you. He's tough.
Yeah. I just had one question. So the Cefepime is recommended when the MICs are like less than 2, and if not, like go to like carbapenems, right? So in that case, like should we be releasing the MICs for those organisms, or because I don't know if we're like always not involved in the care of these patients, but I'm not sure if.
I mean, this is just my opinion. I think with Epic, I think MICs are going to be available. So unless I'm wrong, I think we're going to see MICs. So it shouldn't be a problem. First of all, for bloodstream infection, I think it's always carbapenem. I mean, I wouldn't go to Cefepime, certainly not initially there. I think the data, we just, that's what the data is telling us.
We had a discussion, I believe, just to go back to the MIC question, that, we had discussed with Tom and Mel, about whether to report MICs routinely and for all organisms. And the answer to that was no, because people don't know how to interpret those results in general.
I respect that, but I personally like MICs influence my decisions. And I think in EPIC, we have the potential to restrict MICs to certain groups, like the ID physicians, the stewardship pharmacists. So I think that would kind of be the best of both worlds, except for maybe not all ID doctors interpret MICs right. But I know it certainly helped me prescribe. So, and hopefully EPIC will create new opportunities where we can limit it. But yet, I think, how often do you see an Enterobacter with, I guess you can see with MICs of 4 to 8. Usually when I see an AmpC, and we're not really talking about Enterobacter, when you really see these AmpCs and they're susceptible to Enterobacter, I don't see too many that are 4 to 8. I don't know, Nav, is that something that you see a lot of?
No, I was actually just looking at that a little bit ago, but one thing I'll show you for the fellows is, so you can look at different MIC distributions. So if you go to the UCAST website, right, I've showed you the M100 like numerous times, right? But the European version of CLSI, right, the UCAST website, if you go there, there's a spot where you can just look at this. And this is not for you to do like while you're on the floor seeing patients, but just like as you have some downtime to understand these questions. But you can look at these distributions, and it's actually pretty easy to look at them. And you can just pick your bugs, right? You can pick all these bugs. So if you look at Enterobacter, for example, you can see the distributions of all the different drugs, right? So like Cefepime, most of them live pretty low, right?
Are those MIC 50s, Nav, or those MIC 90s in blue, do you know? Or are those just susceptibles?
These are just susceptibles. So this is the distribution, so the frequency distribution. And then you can see the ECOF, which I think is like kind of essentially like the MIC 99.5 is pretty low,
Really?
Right? So, most Enterobacters in this example, right, are going to have pretty low MICs. So, Divya, do you remember, why the IDSA guidelines say that to, only if it's below 2, like then you can trust it, but if it's 4 or 8, then, you should be suspicious and maybe use something else? It's a sort of a good point, and then I'll ask something else after that I think is helpful. But I don't think Tom and Mel are here, so that would have been better. But there's potential or thought, remember, for co-production of ESBL, right? So if you have a higher MIC, then it's like, oh, maybe it's not just AmpC, and maybe there's some, acquired ESBL production, right? The only problem, and what I wonder is how well in the micro lab with routine testing can you discriminate an MIC of 2 or 1 versus 4 and 8? Like, is there such high variability that it's going to be hard to make that cutoff? I mean, hopefully most are very low MICs, and then it would be an issue.
I just might ask, like, I think it's common sense to us that if we see something, for us, if we see some of the Cefepime MIC of 8, and it's, it's a serious infection we want to treat, we probably use a carbapenem, right?
Yeah.
So, I guess my question is, what's the data that 4 is the magic? I mean, is there great data that increasing MIC? I mean, I think they just kind of picked that out because it sort of makes common sense, but I don't even know there's great data behind it.
I think they look, because I haven't looked at it in a while, but I think they've looked at the distributions with known ESBL co-production and looked at how the distribution is shifted in that way. And I think there's better discrimination around that point. Yeah. I think that's what it is.
Just saying, like, I think it's more of but it's not like based on clinical data that you can't treat a urine with an MIC of 4 or 8.
Right. I mean, exactly. I mean, there's a lot of those things in this.
It makes sense, but I'm just saying.
Yeah. I think there's a lot of those things in this guidance that you sort of have to take with a grain of salt and think a little bit about it.
I think a lot of ID you have to take with a grain of salt. I mean, you know, we know
Yeah.
a few things well, but there's a lot of unknowns that a lot of things.
So I don't know if this answers your question, Keith, or not, but the IDSA references a study. It says the reason they go with a Cefepime MIC of 4 to 8, they have a likelihood of producing ESBLs in
That's
those
what-
cases, those Enterobacterales. And so they worry, I guess, of an ESBL component maybe. And so they avoid it for 4
Right,
to
but
8.
we can use Cefepime to treat ESBLs if they're susceptible. So I'm just saying, I mean, it makes
Right.
sense. But Nav, can you, I'm not Nav, Ahmed, can you serve as our like election fact checker, I think, for these Eddie Grand rounds? Okay,
Sure.
we want real-time report, the number of errors or the corrections. I think that would be really helpful.
I'll give a summary at the end of the session.
Thank you. So Divya, I don't want to put, I guess I kind of do want to put you on the spot. What's your timeline then? And I really think, just from my experience, when fellows finish their fellowship and they go to practice and real life sets in many ways, even with your best intentions, it can be very, very hard to finish a study. And even if it's just writing it up, which is its own, challenge. So do you have I hope you have somewhat of an aggressive timeline to at least get the analysis done or off the ground before you leave. And I don't know if there's some sort of continuation plan that you and Nav have come up with, if there's someone here who can help keep things alive while you're, moving and becoming a full-fledged ID attending. So, or a hospitalist attending. What are your thoughts?
So I'm working with Nav's PharmC student as well, and it's her honors project. So she's helping with data collection, and there's also another medical student who just started on this project who's also helping with data collection. So we initially thought of just looking at the Citrobacter isolates, not only blood, but like the other ones.
Mhm.
So I think that should be done pretty soon. And then we'll have to go on to like the Enterobacter.
Right.
And Divya, we might, and not to cut you off, Keith, but we might even just, focus on Citrobacter, because that's, from a feasibility standpoint, right? Like once we get, all the Citrobacter isolates, we accumulate that from the other sites. That might be.
Yeah, this might be, and that might be something that Divya can lead with your honors student as a second author. And then if you want to do Enterobacter, that might be your honors project. You know what I mean? With Divya helping. I mean, there might be a win-win here where you can get a couple pubs out of this for both of you guys.
Yeah. I mean, you saw there was
we could talk offline.
Multiple objectives and aims. And
Right.
the point of that is to, and you can extract a couple questions out of there. So yeah, Divya, I think you did a nice job sort of summarizing, because it is sort of complicated design because there are multiple things that we're looking at. But I think you did a good job of, tying in all the background to why we're looking at all these different aims and outcomes and things like that.
Thank you.
And Divya, it looks like the 10 people out of the study by Lee et al. That the IDSA references, the 10 people had an MIC. So a subgroup of folks who had Enterobacter with an MIC of 4 to 8 for Cefepime, actually all of them died. That's a small number, right? So you have to think about the bias. Were those 10 people just generally sicker? So without going into the biases, I think that probably scared them, and you probably need more data. So just to complete, as what Keith said, the fact check, they quote that directly as their reason for suggesting it,
I mean,
which is kind of nice of the authors of the IDSA document to say, it's a small number, but this is our reason, and they reference it directly, which is good.
and I think, that's a pretty hard outcome. So you're not going to argue with death.
Yeah.
There
Well,
could be something there,
apparently the folks who had a lower MIC, I think most of them didn't die, so they were like within.
If you said they all died too, I'd say, yeah.
Yeah.
So
Any
guys,
other questions or comments?
I wanted to give just a shout out for the graduation lunch on Thursday at noon. MEB, help me, 103 Pinky?
108, 108A.
108A.
Thank you, Vin. And I think we're considering doing the faculty meeting from that same room, since we'll all be assembled there, unless there's a problem. I asked Jolene to see if we can hold the room till later. But Divya, great job. Thank you so much.
Thank you.
Thanks, Divya. That was great.
Yeah, very good.
Thank you. Bye.
Bye.